Okay, we will proceed with plenary lecture number 2. It is my honor to introduce our speaker, Dr. Prudence Francis. She is the clinical head of breast medical oncology at the Peter MacCallum Center in Melbourne and chair of the steering committee in the SOFT-ATTEX trial. She's a member of the St. Gallen Primary Breast Cancer Consensus Panel, the International Advanced Breast Cancer ABC Consensus Panel, and the EBCTCG Steering Committee. The title of the presentation is Premenopausal ER-positive breast cancer, past, present, and future. Dr. Francis, you have the podium.
Thank you very much, Carlos. It's great to be here in San Antonio. And 30 years ago, I was privileged to be offered an oncology fellowship in the United States before I returned to Australia. And it's a real honour to be here now and giving a plenary lecture today. And I'm going to focus today on premenopausal estrogen receptor positive early breast cancer. I have nothing to disclose. So I'm first going to take a little trip down memory lane to look at what we learned from previous clinical trials. And I'm going to take you back 30 years ago to the Oxford Early Breast Cancer Trialist Collaborative Group meta-analysis of adjuvant ovarian ablation trials in women under the age of 50. And you can see on this slide that adjuvant ovarian ablation compared to a control showed a very significant improvement in recurrence-free survival and overall survival, with a larger absolute benefit in those with node-positive than node-negative disease. Moving forward to 2005, this same group did a meta-analysis including the trials with ovarian ablation, but also subsequent trials with a reversible form of ovarian suppression in women under 50. And what you can see in this meta-analysis is that there is less separation of the curves as compared with the previous slide. And in my opinion, this is probably because in this more recent meta-analysis, there were more women under the age of 50 who were receiving long-course alkylator chemotherapy, likely to make them postmenopausal despite being under the age of 50. And in fact, when they looked at the effect of adjuvant ovarian ablation or suppression on breast cancer mortality, and they looked at whether it was given on a background of chemotherapy or no chemotherapy, it did appear that the effect on breast cancer mortality was smaller if chemotherapy was also given. So we're getting these early hints of the interaction between chemotherapy and ER-positive breast cancer and ovarian suppression. Now moving forward to 2011, the meta-analysis was published with mature 15-year data looking at the effects of 5 years of adjuvant tamoxifen versus no adjuvant tamoxifen. And here I'm showing you a selected data set in women under the age of 45, so likely to be in a premenopausal age group with ER-positive tumours. And again, you can see that 5 years of tamoxifen provides a very significant reduction in recurrence and also an improvement in breast cancer mortality. So if we look at the effects in these women under 45, over 15 years, breast cancer mortality was reduced by 1/3. The risk of a new contralateral breast cancer over the subsequent 15 years was halved. And tamoxifen actually has a more favourable safety profile. In this age group, in this analysis, there were no deaths from uterine cancer or pulmonary embolism. We also learned from the meta-analyses that while the relative risk reduction achieved by tamoxifen was independent of nodal status, there was a greater absolute risk reduction in node positive, similar to what I showed you with the adjuvant ovarian ablation slide previously. But different to ovarian ablation and chemotherapy, we learned that tamoxifen actually gave clear additive benefit after chemotherapy in premenopausal women with estrogen receptor positive breast cancer. And interestingly, when you look at the curves, there is early separation of the disease-free survival curve if premenopausal women receive tamoxifen after their chemotherapy versus no tamoxifen. But you can also see that the overall survival difference takes a long time to emerge in ER-positive breast cancer in premenopausal women. And I think that's really important when we talk later about trials like the SOFT trial. We really do need to wait for long-term follow-up to really understand what will happen. One of the more sobering analyses published by the Early Breast Cancer Trialist Group was this publication where they looked at the risk of late distant recurrence in ER-positive breast cancer. So in this analysis, patients had received 5 years of adjuvant endocrine therapy and then ceased their adjuvant endocrine therapy, and they were disease-free at the 5-year time point. And this is looking at what was the likelihood of developing a late distant recurrence between years 5 and 20 according to their baseline tumour stage. And what was sobering in this analysis was the progressive events of late distant recurrence, and even in the patients with the lower stage tumours, the T1 N0 tumours. 3 years ago at this meeting, they had a further look at this data, and they looked at the patients with the node-negative disease, and they looked at distant recurrence during years 5 to 9, according to the year that the patients were diagnosed. And somewhat encouragingly, the patients who were diagnosed this century, so from the year 2000 onwards, seem to have a relatively lower risk of late distant recurrence than those who were diagnosed before 2000. Nonetheless, late distant recurrence remains a phenomenon of ER-positive breast cancer. And it underlies the importance of trials like the ATLAS trial. And the ATLAS trial here, I'm showing you a data set in patients who had estrogen receptor-positive breast cancer. They had had 5 years of tamoxifen. They could have any menopausal status. And here, the patients were randomised to extend tamoxifen to 10 years or stop at 5 years. And there was a significant reduction in the risk of recurrence and a significant reduction in the risk of breast cancer mortality. And you can see that the absolute separation of the curves is not large, but you've got about 3 or 4% there. Now, I want to take you through a few other relevant observations from premenopausal estrogen receptor-positive early breast cancer trials. One really important observation is that very young premenopausal women under the age of 35 with ER-positive tumours had a higher risk of relapse than the older premenopausal women with ER-positive tumours. The IBCSG was the first to make this observation, and they looked at their older chemotherapy trials in premenopausal women, and they broke the premenopausal women down by age, less than 35 or over 35. And as compared to the women who had ER-positive tumours, premenopausal over the age of 35, those who were ER-positive were under 35 years of age stood out as having a higher risk of relapse. IBCSG invited the US cooperative groups to look at their data, and they all showed the same phenomenon, that there was a problem in the young women with ER-positive breast cancer. Other important observations from trials is that premenopausal women who develop amenorrhea after chemotherapy had a lower risk of relapse than those who continued to menstruate. But the likelihood of developing chemotherapy-induced amenorrhea actually increases with older premenopausal age, and amenorrhea is less likely under the age of 35. So now moving to current evidence and practice. I think fertility is an important consideration in premenopausal women. I recommend avoiding hormonal contraception in patients with ER-positive breast cancer and using non-hormonal methods. It's recommended that a fertility consultation be offered if childbearing is not complete. Brief use of hormone treatment for fertility procedures is acceptable in ER-positive breast cancer. And if future pregnancy is desired and chemotherapy is planned, consider also starting a GnRH agonist at least 1 week prior to chemotherapy. I want to briefly talk about ER low positive. This category is defined as estrogen receptor positive in only 1 to 9% of cells. And while patients in this category might derive benefit from adjuvant endocrine therapy, these tumours actually often behave more like triple negative tumours. And I want to point out that these patients were not eligible for SOFT unless they had at least 10% of cell staining with one of the hormone receptors. Now I'm going to take you through the SOFT trial and the most recent data. So SOFT was conducted in premenopausal hormone receptor positive breast cancer adjuvant trial, and there were three adjuvant endocrine therapy regimens. Standard regimen was tamoxifen for 5 years. It was compared to tamoxifen plus ovarian function suppression as the primary comparison, and a third arm with an aromatase inhibitor exemestane plus ovarian function suppression for 5 years. Just over 3,000 patients randomised, and the patients entered into the trial were stratified according to the receipt of prior chemotherapy or not. It was optional as decided by the patient and the doctor whether they had had prior chemotherapy, and it was just under half the patients had no chemotherapy. The patients who'd had prior chemotherapy had to have a premenopausal estradiol level at a local lab within 8 months of completing chemotherapy to be eligible for the trial. Now, this is the most recent data. With a median follow-up of 12 years, we have the disease-free survival, and all these slides are colour-coded so that the tamoxifen alone is the black curve, the red curve is tamoxifen plus ovarian suppression, and the blue curve is the aromatase inhibitor exemestane arm. You can see that the disease-free survival with the addition of ovarian function suppression to tamoxifen as compared with tamoxifen alone is significantly improved with an absolute benefit of around 4% at 12 years. There's a further improvement in disease-free survival with the aromatase inhibitor plus ovarian function suppression arm with an absolute difference of around 7%. If we look at overall survival, you can see that there's not very much separation in the curves. I want to point out to you that the SOFT trial overall population was not particularly a high-stage disease. Only 35% of the patients had positive lymph nodes. And when we look at the 12-year median follow-up, you can see that the two arms where patients were assigned to receive ovarian function suppression had absolute improvements in overall survival of just over 2% as compared with the tamoxifen alone arm in the overall population. Now, I want to look at the two cohorts separately. This is the no chemotherapy cohort. An important feature of this cohort is the median age of 46, so not far off natural age of menopause. And one of the things, when we look at the distant recurrence-free interval in these patients, the results are really excellent. In fact, you can see they're all above 95%, even with tamoxifen alone. And perhaps these are even better than what has been seen in TAILOR-X in the patients with the recurrence score of 0 to 10, even though most patients in this trial would not have had access to a multi-gene assay. So perhaps doctors and patients were quite good at selecting who did not need chemotherapy. The other encouraging thing is that overall survival is greater than 95% in all three arms. So tamoxifen alone is an appropriate treatment for some premenopausal patients with selected features. Moving now to the prior chemotherapy cohort, this had a younger median age of 40. If we look at the distant recurrence-free interval, you can see absolute improvements with ovarian function suppression compared to tamoxifen in both arms. And if we look at overall survival, we've got at least 4% absolute improvement in overall survival in both the ovarian function suppression arms. We also wanted to focus on the HER2 negative subgroup, and that's because when this trial was started, trastuzumab was not standard of care for HER2 positive, but the HER2 negative patients all were treated more or less as we would now. And if we look at the patients who had prior chemotherapy for HER2 negative tumours, we see that there is some separation of the curves, and you can see absolute improvements in overall survival at 12 years by adding ovarian function suppression to tamoxifen and some further incremental improvement with exemestane plus ovarian suppression. And the difference between the two ovarian function suppression arms is 3.3% at 12 years. There has been a premenopausal estrogen receptor positive meta-analysis conducted, and that was looking at 4 trials in which the randomisation was to an aromatase inhibitor with ovarian suppression versus tamoxifen and ovarian suppression. One of these trials was the SOFT trial, and there were 3 other trials. And what they found was that distant recurrence was significantly reduced with the use of the aromatase inhibitor and ovarian suppression as compared with tamoxifen and ovarian suppression. And if we look at the forest plot here for distant recurrence, it appears to be relevant to get an aromatase inhibitor with ovarian suppression if you have a HER2 negative tumour. So what about these very young women under the age of 35? Do they need ovarian suppression? In SOFT, nearly all of these women got chemotherapy. But if we looked at the patients who were assigned to tamoxifen alone without ovarian suppression in this age group who had HER2 negative tumours, at 12 years, nearly 1 in 2 had had a further invasive breast cancer event. And if we look at the overall survival in this group, if they're under 35 HER2 negative tumours, about 1 in 3 have died if they were assigned tamoxifen alone. And there is a meaningful overall survival improvement of at least 7% at 12 years in this age group in both ovarian function suppression arms. In this diagram here, you can look at the 3 treatment arms, and what I want to show you is that there are some subgroups in SOFT with HER2-negative cancers where we might make quite an impact in the overall survival. And I'm looking here at patients who had neoadjuvant therapy before they entered the trial. We know that patients with neoadjuvant therapy often have higher stage tumours, more aggressive biology. Also, very young patients seem to derive incremental improvement from intensification of adjuvant endocrine therapy, as well as higher nodal burden. And grade 3 tumours also seem to derive a particular benefit from having the aromatase inhibitor with ovarian suppression. I'd remind you there are guidelines from ASCO on ovarian function suppression published previously. I think it's important to acknowledge that ovarian function suppression with an aromatase inhibitor or tamoxifen does affect quality of life. Some of these problems, like hot flushes, may attenuate over time if you look from 6 months, the difference in the arms compared to tamoxifen, and over time that appears to attenuate. But I think there are other problems like loss of sexual interest, which is more marked with an aromatase inhibitor, that does not particularly seem to attenuate from 6 months to 60 months. And I think these side effects are very important for these young patients. Non-adherence is common over time in young patients, and I'd point out to you that the results I've shown you in the SOFT trial are intent to treat analyses, and in fact at 4 years 22% of patients were no longer continuing their ovarian suppression in the SOFT trial. We know that from other studies that non-adherence is associated with an increased risk of cancer recurrence, so paying attention to side effects and trying to improve quality of life might help our patients. It's important also, if we're giving ovarian suppression, to remember bone density, and remember that these patients can benefit from bisphosphonate infusions to reduce not only bone loss but potentially metastasis risk as well. Are there other results testing ovarian suppression that are consistent with the SOFT trial results? The ASTRA trial, conducted by our Korean colleagues, actually has results that are consistent with the SOFT prior chemotherapy cohort. And I'd bear in mind that both ASTRA trial and the SOFT chemotherapy cohort had the same median age, patients of 40 years. And the ASTRA trial was slightly different to the SOFT trial. Patients had adjuvant chemotherapy, they were under 45 years of age, and they received tamoxifen for 5 years. And if they could demonstrate some ovarian function within 2 years after chemotherapy, they could be randomised over time. And they got 2 years of goserelin rather than the 5 years of ovarian suppression in the SOFT trial. Their 8-year data was presented at ASCO last year, and there is a significant improvement in disease-free survival with the 2 years of ovarian suppression added to the 5 years of tamoxifen. In their secondary outcomes, they do show a significant reduction in distant metastases at 8 years. So we have a real menu of strategies for the clinic, and when you're at lower risk, tamoxifen alone is appropriate, and as the risk of recurrence gets higher, I lean more towards the aromatase inhibitor with ovarian function suppression. So how to decide what adjuvant endocrine therapy to choose? Meredith Reagan has worked on a composite risk, and really this is combining clinical pathologic factors together to combine them all together to see how this might play out. And these are the factors that were considered in this. And in fact, she has developed an application that you can find online, and this was looking at the distant recurrence risk with the 8-year data from the trial. So if you haven't looked at this before, it gives you the outcomes according to the different treatment assignments in the SOFT and the TEX trials, so you can have a look at this. Who would you give tamoxifen alone to in a premenopausal estrogen receptor positive breast cancer, and particularly if you did not have access to multi-gene assays? I think older premenopausal ages is relevant here. HER2 negative, node negative, T1, grade 1 to 2 tumours, having good percentage of cells for both ER and PR, and a low key 67. So what do we think might be coming in the future? I draw your attention to the positive trial. It's really important in our young women now when we're talking about maybe up to 10 years of adjuvant tamoxifen, about whether we can actually interrupt adjuvant endocrine therapy to think about childbearing. And the positive trial has been a wonderful collaboration trying to look at this important question for our young patients. And this will be presented, the first results from this trial, on Friday. So I draw your attention to that. Is this a safe option in ER-positive premenopausal breast cancer? Another thing I think that's worth thinking about in the modern era is if we're going to be thinking about adjuvant abemaciclib, is there another reason to consider adjuvant aromatase inhibitor plus ovarian function suppression? Another reason might be that there is actually a lower risk of venous thromboembolism if you combine adjuvant abemaciclib with an aromatase inhibitor as compared with tamoxifen. And when they've looked at their premenopausal data in the Monarch-E trial, if you are receiving, a premenopausal woman receives an aromatase inhibitor as her initial endocrine therapy, there was a 1% risk of a thromboembolism, but 2.7% with tamoxifen. So if you're thinking of abemaciclib, this might be another reason in a high-risk patient, apart from perhaps a lower risk of distant recurrence that I've shown you before from the SOFT trial, to consider an aromatase inhibitor. What endocrine options might be coming in the future? So apart from GnRH agonists, which were used in the SOFT trial, there are GnRH antagonists, and IBCSG did do a trial with degarelix, which shows very quick and full suppression of estrogen with degarelix. There are also oral GnRH antagonists coming, and I think it would be wonderful for patients if we could give an oral thing. No patient likes to turn up every 4 weeks for an injection. We don't really have breast cancer data yet, but maybe we'll have this in the future. And I think oral SERDs will be an important consideration, maybe as an alternative or to sequence after oral endocrine therapy. Can we predict which big adjuvant endocrine therapy trials we could conduct in the future based on biomarker response to endocrine therapy in smaller, shorter preoperative trials? This is actually from postmenopausal trials like ATTACK and Big 198 and FACE and MA27. All these short biomarker trials looking at Ki67 did show that you maybe could have predicted those results. So could we have predicted the SOFT results by a biomarker study? In fact, the West German study group actually presented some results on Ki67 suppression in their ADAPT cycle trial at ESMO recently. And you can see here they've got tamoxifen alone in the blue, they've got tamoxifen and ovarian suppression in the gold, and the aromatase inhibitor plus ovarian suppression in the green. And you can see the degree of Ki67 suppression. Now, these premenopausal women had a very short, I think it was about a 2 to 4 week endocrine period looking at this. And so perhaps we could have predicted the results of the SOFT trial because these results are actually consistent with what we saw. What do we need in the future for premenopausal ER-positive breast cancer? We know from TAILORx, RxPONDER and MINDAC that we do have concerns about the safety of omitting adjuvant chemotherapy. So we really do need an answer to when can optimal adjuvant endocrine therapy replace adjuvant chemotherapy in premenopausal ER-positive HER2-negative breast cancer. So taking home some points, adding ovarian suppression to adjuvant tamoxifen does reduce recurrence if there's residual ovarian function. Ovarian function suppression enables the use of an adjuvant aromatase inhibitor in premenopausal women as an alternative to tamoxifen, and it can further reduce recurrence in ER-positive HER2-negative breast cancer. The absolute benefit you will get from using ovarian suppression is really correlated with the baseline risk of recurrence. You'll get more bang for your buck if the risk of recurrence is higher, and you'll also get more effect in very young women. But tamoxifen alone does remain an appropriate therapy if there are low-risk clinical pathologic features. Very young women should be considered for ovarian function suppression. It's appropriate to give a GnRH concurrent with chemotherapy if a woman is desiring a future pregnancy, otherwise you can start it afterwards. Beware of giving an aromatase inhibitor without ovarian suppression if it is a chemotherapy-induced menopause, because that can reverse. If a patient doesn't tolerate ovarian suppression, less than 5 years can provide benefit, as in the ASTRA trial, and the risk of non-adherence is higher in young women. Now, the soft trial data that I've shown you today is actually coming out as a publication in Journal of Clinical Oncology tomorrow, so I draw your attention to that. And I'd like to acknowledge all those who contributed to the soft and text trials, particularly the more than 5,000 patients, our trial statistician Meredith Regan, my soft co-chair Jeannie Fleming, and our text trial co-chairs Olivia Pagani and Barb Wally, and all the funders and the cooperative groups who really made this a first world global effort. So thank you for the opportunity to talk today.
Thank you, Dr. Francis. We have time for questions. Before I hear anybody coming to the microphones, I was stimulated by your slide where you suggested that the ADAPT trial would have predicted the effects of SOFT.
Well, obviously it was done well after SOFT.
Correct, but yeah, no,
it
but I
could
like
have,
the thinking, the reverse thinking. So, thinking about that, do you think there'll be any merit of comparing a SERD, oral SERD, plus ovarian suppression versus an AI plus ovarian suppression, considering that these agents, and I'm looking to the future, you know, may not be that hard on bone?
Well, I think it's an important consideration because we've seen this consistently with all the postmenopausal big adjuvant endocrine trials and now in one premenopausal trial. So I think as long as the period on the endocrine therapy is sufficiently long for the agent to have activity, for example, if it was fulvestrant, you know, you might need a little while longer to get right up to your full loading dose. But if it's something that can act within the time frame, I think it's a very important consideration.
Okay, thank you. Microphone number 4.
You did mention about the various genomic profiling, risk profiling, replacing replacing chemotherapy with ovarian suppression and aromatase inhibitors. So, what's your final thought on it? Is it going to come, or we still have to give chemotherapy?
Well, I'm sure that there are patients, even some with node-positive premenopausal ER-positive breast cancer, who can safely be treated with optimal ovarian suppression plus an aromatase inhibitor. And in the TEXT trial, we have about 21% of patients who have node-positive disease in the no chemotherapy cohort. So I think there are patients, even node-positive patients, who can. It's a question of working out who they are.
Okay. Next question, microphone number 3, please.
Carlos, Mitch Dowsett, London. Prue, that was a lovely summary of the situation. I just wanted to respond to Carlos's highlight in the Ki-67 data from ADAPT and just urge a little bit of caution about the tamoxifen data there. Tamoxifen, as you know, takes about 7 weeks to get to steady state. And in the premenopausal women, the estrogen levels are going up. Mm-hmm. The suppression of Ki-67 by tamoxifen in that group is only 30 to 40%, much less than we see in postmenopausal women. So it may be that it's taking longer to get its maximal effect in those patients. So just a little bit of, I'd love that to be true, yeah. But just a bit of caution.
Yeah.
Thank you for the clarification, Mitch. Microphone number 5, that should be the last question.
Thank you. Laura Testa from Brazil. Thank you for your wonderful work. And I'd like to know your thoughts on patients, very young patients, high-risk patients that completed 5 years of ovarian suppression plus tamoxifen or AI. Would those patients be candidates for extended therapy after 5 years of ovarian suppression?
Unfortunately, it's an evidence-free zone. We don't have any evidence to continue ovarian suppression after 5 years. If we look in postmenopausal women with aromatase inhibitor, thus far we haven't seen very good evidence for reduction in distant recurrence. I think sometimes people will go on with tamoxifen alone as an extension. I think if it's a very locally advanced tumour, you may want to continue, but it is evidence-free.
Actually, we have time for one quick last question, number 4.
Overview. Christoph Thompson from Germany. Very nice overview and good guideline what to do tomorrow. However, I have 2 short questions. One is, how would you integrate the BCI data we saw on Tuesday in your recommendations? And second, use of AI in terms of DFS is quite convincing. However, in terms of overall survival, it's not so convincing.
Yeah, so what I tried to show today, and perhaps we'll have a look in more detail in the publication, is that in the overall trial, we're not seeing dramatic differences in survival, but for individual patient subgroups, it may be really important. High risk, HER2 negative, very young, grade 3 tumours, there may be differences. So have a look at the paper in detail. The BCI data, I think we need to digest it further. Some of the data that was presented was looking at breast cancer-free interval rather than distant recurrence, so I think we will need to look at distant recurrence data as well. But I thank you for the question.
Well, thank you, Dr. Francis. So that concludes this session, and we will proceed next to the Brinker Award presentation.